This section explains what defines a cholinergic agonist. A cholinergic agonist is classified by its effect rather than by its chemistry. Anything that raises signaling through acetylcholine's receptors belongs. That collapses a structurally wild family into one functional class, the parasympathomimetics. The generative move is that a transmitter's action can be amplified from two orthogonal directions on a single loop. One direction is to impersonate the ligand at the receptor. These are the direct agonists, muscarine and pilocarpine. The other direction is to block the esterase that clears it, so endogenous acetylcholine accumulates. These are the endogenous acetylcholine accumulates. These are the indirect agonists, such as physostigmine. Same output, elevated cholinergic tone, reached by two independent levers. Hold that, and the rest follows. The chapter's classification, the toxicity that is just overdose of the same tone, and clinical use as a choice of which lever and where. This section explains what defines a cholinergic agonist. A cholinergic agonist names a role, anything that seats into acetylcholine's receptor and fires it. Chemical structures vary wildly. Identity is fixed by what the drug imitates and where it does so. The chapter installs the book's generative move. A drug's action decomposes into three factors: which transmitter it mimics, which receptor subtype it binds, and where in the body it acts. Bind a muscarinic receptor in the periphery, and you reproduce parasympathetic tone, which is why such a drug is called parasympathetic tone, which is why such a drug is called parasympatho. Lois twin frog hearts is the founding anchor. Perfusate drawn from a vagus-stimulated heart slows a second heart, proving that transmission is chemical and the receptor an addressable target. Every later class adrenergic, antagonist, and CNS you predict by asking only three questions: which transmitter, which receptor, which site. This section explains how the cholinergic antagonists are organized, one transmitter meeting several locks, where the antagonist's identity is which lock it fits, and where that lock sits. One subtraction operation applied at three addresses, applied at. A choline speaks at muscarinic and nicotinic ones, and you get the anti-muscarinics block at the ganglionic nicotinic receptors, the NN type, and you get the ganglion blockers. Block at the neuromuscular junction, the NM type, and you get the muscle relaxants. The move that makes the chapter go through is this. An antagonist has no action of its own. Its effect map is the negative of wherever cholinergic tone was already working. So atropine, non-selective across M1 through M3, reads out as the shadow of vagal tone across every organ at once. The promiscuity is the direct consequence of one drug meeting many parasympathetically governed tissues. Selectivity buys the clinic its precision. This part explains why an antagonist drug has no effect of its own, and how that shapes the way antagonists are classified. An antagonist has no signature of its own. Its entire pharmacology is the negative image of the tone it silences. A cholinergic antagonist binds a cholinergic receptor and does nothing there. The visible effect is simply whatever acetylcholine was holding in check, now released. So, the dose ladder of atropine, secretions first, then pupil and heart, then bladder, then gut, is just the reverse ranking of how tightly parasympathetic tone governs each organ. Classification follows the lock, not the drug. There are muscarinic blockers, nicotinic ganglion blockers, and nicotinic neuromuscular blockers. One silence, three sites. The clinically dominant class is the muscarinic one, atropine, and the belladonna alkaloids. The rest are specialists. This section explains what an adrenergic agonist is at the structural level. An adrenergic agonist is a molecule whose entire clinical identity is a selectivity vector over a 5-element receptor basis: alpha-1, alpha-2, beta-1, beta-2, and beta-3. Each subtype is hardwired to one tissue action. Beta-1 drives cardiac inotropy. Beta-2 drives bronchodilation and glycogenolysis. Ava-1 drives vasoconstriction. Alpha-2 applies presynaptic feedback braking on noradrenaline release. The body already runs this system. Adrenaline and noradrenaline are just endogenous vectors, and the sympathetic fight or flight state is their superposition. A drug is therefore a re-weighting rather than a new mechanism. Sharpen affinity for one coordinate, mute the rest, and you convert a whole body stress cascade into asthma relief or a decongestant. Two routes reach the same vector, bind the receptor directly, or raise the transmitter that does. This section explains how the entire pharmacology of the sympathetic system reduces to one small map. The sympathetic system runs on one small molecular alphabet: the catecholamines, adrenaline, noradrenaline, and dopamine, read by a short basis of receptor subtypes: alpha-1, alpha-2, beta-1, beta-2, beta-1, beta-2, beta-1, beta-2, beta-3, and the dopaminergic receptors D1 and D2. A drug's entire clinical action is just its projection onto that basis. Choose which subtypes a molecule binds, then cross it against where each subtype physically sits: beta-2 in bronchi and vessels, beta-1 in heart, alpha-1 in vasculature, D1 in renal beds. Every effect falls out from that crossing, from bronchodilation to raised cardiac output to vasoconstriction, from bronchodilation to raised cardiac output to vasoconstriction. An adrenergic agonist is nothing but a molecule chosen to light specific coordinates of this receptor tissue map. Learn the map once, and you can predict any sympathomimetic's profile without memorizing the drug. This section explains what an adrenergic antagonist does, and the single idea that governs the whole chapter. Nothing an adrenergic antagonist does is its own. Its entire effect is the sympathetic tone it subtracts. This inverts Chapter 3 exactly. The agonist adds drive. The blocker photographs the standing tone as a negative by removing it. So a drug with no intrinsic action still lowers blood pressure, relaxes prostatic muscle, and blunts a racing heart. That is the chapter's single primitive. Read the sympathetic system backwards. The effect equals baseline minus occupancy. Everything else is addressing. Receptor subtype, meaning alpha-1, alpha-2, and beta, together with site, meaning presynaptic versus postsynaptic, are the routing scheme. They decide which organ's tone gets subtracted. This is why an alpha-1 block relaxes vessels, while an alpha-2 block, hitting the presynaptic brake, paradoxically raises sympathetic output. This section explains how the beta blocker and alpha blocker chapter works as a single pattern rather than a list of drugs. Every drug in this chapter is defined by subtraction. An antagonist occupies an adrenoceptor without firing it, so whatever the sympathetic fight or flight signal would have done through that receptor simply fails to happen. You never memorize the drugs. You read each clinical effect off two coordinates, which receptor is silenced and where it sits. Block alpha-1 on vascular smooth muscle and vasoconstriction drops out, so blood pressure falls and prostatic tone relaxes, which is why these drugs matter in BPH. The alpha-2 case inverts. That receptor is the presynaptic brake on norepinephrine release, so blocking it raises sympathetic output. Selectivity times site generates the entire taxonomy. This is the blockade, half of the adrenergic pair, the agonist chapter run backwards. This section explains why every drug for Alzheimer's disease works only on symptoms and never on the cause. Each drug in this chapter acts one layer downstream of the disease that produces the symptoms. The pathology is amyloid, beta plaques, and tau tangles. That pathology kills neurons. The loss of neurons collapses the cholinergic signal. The collapsed signal produces the memory and cognition symptoms. So the causal chain runs from pathology to neuron death, to a failing cholinergic signal, to the symptoms you can see. Treatment reaches only the last link in that chain. Cholinesterase inhibitors like Dun-Epezol prop up the acetylcholine that the surviving neurons still make. Memantine blunts glutamate excitotoxicity. Meanwhile, the killing itself proceeds untouched. That is the chapter's single thesis. Stated flat in its own abstract, the drugs provide only symptomatic relief and are not able to treat the underlying pathological cause. Grasp that stratification and you can predict the rest. You can see why each agent is palliative, why none of them halts progression, and why the research pipeline chases upstream targets instead. This section explains why every approved Alzheimer's drug treats a symptom rather than the disease. The whole chapter turns on a gap. The pathology is upstream, the drugs act downstream, and nothing bridges them. The cause of Alzheimer's is a cascade. Amyloid beta plaques and tau tangles kill neurons. Yet every approved therapy targets a single consequence of that cascade, the collapse of acetylcholine signaling. Donepezil, rivastigmine, and galantamine all do one thing. They block the enzyme that clears acetylcholine, propping up a depleted synapse. Memantine damps excitotoxic glutamate. The chapter states it plainly, these provide only symptomatic relief and are not able to treat the underlying pathological cause. So the generative primitive is palliation at the accessible node. When the disease-driving mechanism resists intervention, medicine drugs the nearest downstream signal it can still move. This section explains why Parkinson's disease is a control system problem and how every drug class maps onto a single, depleted control variable. Parkinson's is a control system deficit rather than a chemical one. The basal ganglia use dopamine as the balance knob between two opposing loops. A direct pathway running through the D1 receptor says go. An indirect pathway running through the D2 receptor says stop. Together they modulate the glutamatergic input arriving from the cortex. When the dopamine cells of the substantia nigra die off, the set point drifts toward the hypokinetic side, too little movement. Every anti-Parkinson drug class is one lever pushing back toward equilibrium, replacing the precursor, agonizing the receptor, or breaking dopamine's breakdown. This is the chapter's generative move. Read each agent as an intervention on a single depleted control variable, and its side effect profile follows directly. Overshoot the set point, and you get the mirror image, the hyperkinetic state. Dyskinesia. The boundary is what reveals the structure. The knob only rebalances the loop. Nothing here halts the cell. Death itself, so every one of these drugs is symptomatic, and none of them is disease-modifying. This section explains dopamine as the gain on a control system, and why every Parkinson's therapy is correction rather than cure. Dopamine is the gain on a push-pull regulator. The basal ganglia's direct and indirect pathways kill the nigral cells that supply it, and the set point collapses. Too little dopamine gives hypokinetic Parkinsonism. Overshoot it with drugs gives hyperkinetic dyskinesia. Same axis, opposite signs. That one frame generates the chapter's entire therapeutic logic. Levodopa, dopamine agonists, MAOB inhibitors, COMT inhibitors, and anticholinergics are all deviation correction toward a lost set point, never repair. The neurons keep dying underneath, and the correction inherits the regulator's instability. Levodopa's motor fluctuations track its own plasma curve, so the remedy reintroduces the very oscillation it was meant to still. This section explains why a disease with a perfectly known cause still has no therapy that reaches the cause. Huntington's disease has a cause known exactly, a countable CAG expansion in one gene where 40 or more repeats guarantee onset. Yet every drug in the chapter touches none of it. That gap is the chapter's whole structure, perfect etiology, zero causal therapy. What remains is symptomatic patching of the neurotransmitter derangement. The mutation produces downstream. The imbalances are dopamine excess, glutamate excitotoxicity, and GABA depletion. Each imbalance is met by its counteragent, dopamine depleters and neuroleptics for chorea, antidepressants, and others for the known motor burden. The generative primitive is this. When you can name the cause but cannot reach it, management collapses to treating the readout, symptom by symptom, treating side effects against relief. Predict the rest. The drug tables are that logic enumerated. This part explains a disease whose cause is fully solved and whose treatment is entirely downstream, and that gap is the chapter's whole structure. One deterministic lesion, a CAG expansion past 40 in the HTT gene, guarantees the illness. Yet nothing reaches the mutant protein, so every drug named here treats the striatal wreckage it leaves behind. That wreckage resolves to a 3-neurotransmitter imbalance, dopamine in excess, glutamate turned excitotoxic, GABA depleted. Each drug class maps to one arm. Dopamine, depleters, and neuroleptics such as tetrabenazine treat the chorea. Glutamate antagonists such as riluzole and memantine work against the excitotoxicity. The generative move is this. When the root is known but untouchable, therapy partitions the symptom into its neurotransmitter components and hits each one separately. This section explains why the drug treatment of amyotrophic lateral sclerosis can only slow the disease and never cure it. A disease whose cause stays unknown admits only downstream pharmacology. You attack the mechanisms the dying neuron passes through, never the switch that started them, so every drug slows and none cures. That is the whole chapter. Motor neuron death in ALS roots through a listed cascade, glutamate excitotoxicity, free radicals, mitochondrial failure, and stalled axonal transport. The 2 FDA-approved drugs each seize one node. Riluzole damps glutamate release and excitotoxic firing. Edaravone scavenges free radicals. Both by months. The marginal benefit follows structurally from the etiology gap. Interdict one branch of a cascade whose root runs free, and the neuron still dies, only later. This section explains why the 2 approved ALS drugs treat progression rather than cause. 2 drugs, neither curative, and the chapter turns on that concession. ALS kills motor neurons from a cause that stays unspecified, so pharmacology cannot strike the origin. It strikes instead the convergent death pathway that every hypothesized cause funnels through. Riluzole throttles glutamate, excitotoxicity, the overflow of the central nervous system's principal excitatory transmitter, which depolarizes neurons to death. E. Daravoni scavenges the free radicals of oxidative stress. Each buys months, not reversal. The primitive is this: when the cause is opaque, target the shared downstream failure mode. You decelerate progression. You do not rescue the cell. Everything that follows, the nutritional, breathing, speech, and occupational support, is the corollary of that concession. Multidisciplinary management stands in for a cure that remains elusive. This section explains why every anti-anxiety drug is one grip on a control system with many hands on the dial. Anxiety is an adaptive alarm. It is the autonomic, endocrine, and behavioral arousal that sharpens an organism's response to threat. It turns pathological when it fires in the absence of any threat and then sustains itself. Its regulation is distributed across many messengers: serotonin, dopamine, noradrenaline, glutamate, GABA, acetylcholine, adenosine, and histamine each nudge the set point. So every anti-anxiety class is a single-node grip on a multi-node control system. The chapter's organizing law is that grip strength and toll co-vary. The benzodiazepines that most reliably damp arousal are precisely the ones carrying tolerance, dependence, and lethal withdrawal. Read the catalog as levers ranked by the price each one exacts. That co-variation is why the chapter closes by reaching past the drugs toward safer alternatives. This section explains how the chapter frames anxiety and its drugs. Anxiety is cast as a set point disorder, a neurochemical imbalance across serotonin, dopamine, norepinephrine, glutamate, and above all, GABA. So every anti-anxiety drug is one move: perturb a single transmitter axis until the set point resettles. Push GABA chloride conductance up, which is what benzodiazepines do. Damp NMDA glutamate. Tune the monoamines. Each direction buys anxiolysis. The chapter's organizing surprise is that the axis you push dictates the price. Benzodiazepines win on speed and tolerability, yet they carry abuse, tolerance, and fatal withdrawal. That cost per mechanism is why the chapter closes, reaching for safer alternatives. Read it as a catalog index by which neurochemical lever it pulls, and at what liability, rather than by drug name. From the axis an agent targets, you can predict its profile. This section explains why the anti-manic drugs form a single class. Mania is runaway excitation. Dopaminergic and noradrenergic tone is driven past regulation, and the signal transduction cascades. The inositol cycle, GSK, and the sodium-potassium, ATPC, are stuck open. The chapter's organizing move is that these drugs form a class by function alone. Anticonvulsants, a bare alkali metal cation, benzodiazepines, and antipsychotics have nothing chemically in common, yet all of them converge on damping the excess. That is why lithium, a monovalent ion merely impersonating sodium, is the prototype rather than an outlier. Read the classification table as a functional equivalence class. Membership is: this compound suppresses the manic drive. The diversity of entries is the evidence that mood stabilization is a target you can reach from many chemical directions. The drug is defined by what it quiets. This section explains why mania behaves the way it does and why its whole pharmacology follows from one idea. Mania is a gain pathology, not a content one, and the entire pharmacology follows from that single inversion. Anything that raises dopamine or noradrenaline activity precipitates it, and anything that lowers activity alleviates it. so a mood stabilizer is an amplitude clamp on the catecholamine loop, nothing more exotic than that. Lithium is the chapter's anchor because it embodies the trick structurally. It is a monovalent cation, light enough to impersonate sodium and potassium, slipping into their transport roles and detuning the downstream second messenger cascades the neuron uses to amplify signal. The bipolar swing is an oscillator whose gain has run loose. The drug does not pick a target so much as lower the whole system's responsiveness until the excursions stay bounded. This section explains how every sedative and hypnotic drug is one knob on a single inhibitory channel, the GABA, a gated chloride pore, and how the whole chapter is the geometry of one dose-response curve. Calm, sleep, anesthesia, coma, and death all lie on the same axis. What separates the drug classes is the way each one grabs the channel. Benzodiazepines only raise its opening frequency when endogenous GABA is already bound, a modulator whose curve flattens into a ceiling. Barbiturates open the pore themselves at high dose, an agonist with no ceiling, and therefore lethal. The safety margin simply is that curve slope. Every later agent, the Z drugs, the melatonin drugs, and the orexin drugs, is a hunt for the same modulation with a cleaner ceiling. This section explains that every sedative drug in this chapter is a single design choice made on one axis. Sedation, hypnosis, anesthesia, coma, and death are graded depths of the same central nervous system. Depression, one continuum traversed by dose. What looks like a list of separate effects is the same effect seen at increasing depth. Every drug here is a move on one design variable, the slope of that dose-response curve. Barbiturates gate the GABA, a chloride channel directly, so the slope is steep, and the hypnotic dose sits close to the lethal one. Benzodiazepines only modulate a channel that GABA has already bound, raising the frequency at which it opens. No ceiling is breached without GABA present, which flattens the curve and pushes lethality far from efficacy. Safety is that gap. The whole generational history, from barbiturate to benzodiazepine to Z-drug to melatonin and orexin, is the search for an ever flatter slope. This section explains why every antidepressant is a variation on one idea and how that idea predicts each drug's side effects. Every antidepressant is one answer to a single equation. Raise monoamine concentration in the synaptic cleft. The chapter frames depression as a monoamine deficit, so the entire drug lattice generates from two intervention points on the transmitter's life cycle. You can block its degradation, which is what the MAO inhibitors do, or you can block its reuptake, which is what the MAO inhibitors do, or you can block its reuptake, which is what the transporter blockers do. Cross those two intervention points with one further axis, selectivity. Selectivity asks which of the three monoamines a drug hits, serotonin, norepinephrine, or dopamine, and whether it also grabs off target receptors, the alpha-1, the H1, and the muscarinic. That second question is the side effect profile itself. TCA promiscuity buys cardiac and anticholinergic toxicity. SSRI selectivity trades that away at the cost of sexual dysfunction and suicidality. MAOIs add the tyramine and hypertensive trap. You can predict any class the authors list by naming its point on the life cycle and its selectivity vector. The mechanism dictates both the efficacy and its characteristic cost. This section explains the one move every antidepressant makes and the taxonomy that follows from it. Every antidepressant makes one move. It raises the standing concentration of a monoamine oxidase, noradrenaline, or dopamine in the synaptic cleft. It does this in one of two ways, either by blocking the monoamine's clearance through the reuptake transporters or through the monoamine oxidase enzyme that eats it, or by retuning the autoreceptors that throttle its release. The whole taxonomy the chapter enumerates is one-axis read across generations. First, the monoamine oxidase inhibitors, then the tricyclics, then the selective serotonin reuptake inhibitors, the serotonin and noradrenaline reuptake inhibitors, and finally, the atypicals. Read across those generations, the atypicals. Read across those generations, the axis is a single trend. Narrow the target so that fewer other receptors are touched. The consequence that does the work is this. A drug's side effect profile just is its remaining promiscuity. The tricyclics block cardiac sodium and muscarinic receptors. The monoamine oxidase inhibitors interact with dietary tyramine, so you can predict the adverse effects from what the molecule still grips. This section explains how the entire antipsychotic class hangs on a single receptor. One receptor carries the whole class. Block dopamine's D2 site and psychosis softens. This is the dopamine hypothesis turned into a drug. Every first-generation agent is a variation on that single antagonism, and the price is written into the mechanism itself. Choke D2 hard, and the motor and hormonal wreckage follows. Extrapyramidal symptoms, hyperprolactinemia, orneuroleptic malignemia, and neuroleptic malignant syndrome. The chapter's pivot is one anomaly. Clozapine works while barely touching D2. A member that ignores the class's defining move forces the receptor map to widen toward serotonin and other central sites. And the typical versus atypical split is exactly that widening. Here is the generative rule. Name a drug class by its target, then let the exception that keeps the effect without the target rewrite what the target was. This part explains why antipsychotic drugs cause movement problems and how the drug family evolved to escape that trap. Block dopamine at the D2 receptor and psychosis recedes. But that same receptor runs motor control, so the therapeutic effect and the extrapyramidal damage ride a single lever. The whole drug family is a series of attempts to pry those two apart. The typicals clamp D2 hard and pay for it in movement disorders. The atypicals loosen the grip and recruit serotonin, buying the antipsychotic effect at lower motor cost. Clozapine is the anomaly that fixes the axis. It barely binds D2, yet it works, which forced the dopamine hypothesis to bend. Here is the generative move. When cure and harm share one mechanism, a drug class evolves by decoupling them rather than by pushing harder. Read each generation as a gain in selectivity. This section explains why the anti-epileptic drug catalog collapses into a single idea. A seizure is one thing, a local collapse of the balance between excitation and inhibition, where a patch of cortex fires a hypersynchronous, self-propagating burst, the paroxysmal depolarizing shift. Read that as the generative primitive, and the entire drug catalog stops being a list. Every anti-epileptic, however chemically unrelated, pulls one of a very small set of levers on that balance. It can damp excitation by blocking the voltage-gated sodium and calcium channels that carry the burst, or by blocking glutamate at the NMDA and AMPA receptors, or by blocking glutamate at the NMDA and AMPA receptors. The chapter's worked figure is the tonic-clonic cycle read as GABA loss alternating with AMPA and NMDA excitation, and it is the whole thesis in miniature. Restore the inhibitory margin, and you can place any drug's mechanism before reading it. This section explains why the whole pharmacology of seizures reduces to a single lever. A seizure is one failure mode wearing many masks. hypersynchronous cortical discharge, neurons firing in lockstep when they should stay independent. The chapter's whole pharmacology collapses to a single lever, the excitation to inhibition balance, and a handful of channels that set it. Sodium and T-type calcium carry the runaway depolarization. GABA carries the inhibition that normally contains it. Glutamate through NMDA and AMP feeds the spread. Every anti-epileptic drug does one thing: push that balance back toward inhibition, either by damping the excitatory channels or amplifying GABA. So seizure type indexes which channel dominates, and drug choice reads straight off it. The pathophysiology and the treatment name the same few gates. This part explains the whole class of local anesthetics as one molecule wearing two faces switched by pH. A local anesthetic is an amphiphilic weak base poised between a neutral form and a protonated cation. The neutral form is the delivery vehicle, lipid-soluble enough to cross the nerve sheath. The cation is the actor, trapped in the more acidic axoplasm, where it plugs the voltage-gated sodium channel from inside and stars the axon of its action potential. Every clinical number is a shadow of this split. The pKa sets onset. Liposolubility sets potency. Binding strength sets duration. Progress the two form equilibrium and you regenerate the chapter. Ester versus amide is merely which linker carries the molecule. This section explains how a single local anesthetic molecule works by existing in two interconvertible forms. A local anesthetic is one molecule wearing two forms, switched by pH. Every clinical local anesthetic is a weak base with a pK and near physiologic pH, so it sits in equilibrium between a neutral species and a protonated cation. The neutrophil is the only one lipophilic enough to cross the nerve membrane. The cation is the only one that binds the voltage-gated sodium channels in a pore, blocking the sodium influx that an action potential needs. So the drug must be uncharged to arrive and charged to act, a sequential conditional gated by local pH. Potency, onset, and why acidic inflamed tissue resists blockade all fall out of that single equilibrium.